I am Dr. Suraj Pandey, and I'll be covering today in my lecture topic Recent Advances in Periodontology, Part 1. Now, the first thing we should cover in this is periodontal microsurgery. Now, definition: periodontal microsurgery is defined as refinements in existing basic surgical techniques that are made possible by the use of the surgical microscope and subsequent improved visual acuity. References to magnification date back to 2800 years from the ancient Egyptians. In 1964, Antony van Leeuwenhoek constructed the first compound microscope. In 1921, Carl Nain, the father of microsurgery, first used microscope for ear surgery. It was Apotheker and Jaco who first introduced the microscope to dentistry in 1978. Now, this is the there is something called as microsurgical triad, which is the combination of precision, illumination, and magnification. Now, the first and the primary magnifying devices used in dentistry are loupes. Now, they can be classified either into simple loupes, then we have compound loupes, and then comes the more advanced and coaxial lighted prism loupes. Now, loupes are fundamentally dual monocular telescopes with side-by-side lenses. They follow Keplerian optics, that means the convergent lens system. The magnification range is 1.5x to maximum 6x. Now, what is the disadvantages? Because of the convergent lens system, they have eye strain and fatigue, small view, depth of view and field of focus, and excessive weight. The only advantage is the cost factor. Now, coming to the surgical operating microscope. Operating microscopes employ Galilean optics, that is stereoscopic vision without eye convergence. Magnification up to 20x allows the dentist to change the working magnification and makes documentation of cases possible. Advantages: far better versatility, stereoscopic viewing without eye convergence, reduces eye strain and fatigue, provides highest resolution and illumination, provides variable magnification, severe fold increase in depth of focus and field of view, and no separate light source required. There is a separate armamentarium. The microsurgical instruments are made of titanium. They create incisions which heal by primary intention. Incisions are established at an angle of 90 degrees to the surface. Microsutures, they are in the range of 6 to 90. Wound apposition with minimal gap and ragged edges is present, and good motor coordination with the precision grip. The next topic we'll be covering today is lasers. Well, laser, the full form is light amplification by stimulated emission of radiation. It is a coherent, monochromatic, and collimated form of light. Myman invented the first laser device in 1960. Water molecules, proteins, pigments present in the biological tissue absorb the energy. Well, interaction of the human tissue with laser can be in the form of either absorption, transmission, scattering, or reflection. They cause hemostasis and they cause soft tissue ablation. The advantages of a laser system are the greater hemostasis, bactericidal effect, and minimal wound contraction. Now, there are various lasers in dentistry like excimer lasers, gas lasers, diode lasers, and solid state lasers. Well, precautions before and during irradiation is use glass for eye protection, prevent inadvertent irradiation, protect the patient's eyes, throat, oral tissues, use wet gauze packs to avoid any reflection from shiny metal surfaces, and ensure adequate high-speed evacuation. Potential risks: excessive tissue destruction by direct ablation, destruction of attachment apparatus at the bottom of pockets, excessive ablation of root surface, and thermal injury to the root surface, gingival tissue, pulp, and bone tissue.